You know, one of the things to get away from in thinking about people who struggle with mental health issues is that it's about them over there, and then there's us over here, and they're the one with the problems, and we're the people who sort them out. And of course, the medical model has been built around that sort of separation between the expert and the sufferer, the white coat and the bed. And you know, it's just so helpful if we make our starting point that in many ways we're all in this together. We're all strugglers in different ways. And what I'd like to do is I'm going to share a little out of some of my own experience as we talk. I'd love it if you could share a little out of yours, provided you feel safe and comfortable doing that. So if you feel able to share a little about something you struggled with, then I think that would be great. But please, only if you feel comfortable that having done that, you won't be opening up something in your own heart that would be hard to close down. You know, but you'll know whether you can do that. And if you feel able to share, I think that'd be great, because it just breaks down this idea that we're dealing with them out there and we're the experts, because we're not. We're all finding our way together. Now, what I'm going to do is cover the medical approach to depression, not because it's the only one or necessarily the right one, but because it's a very popular and prevalent one, and it's a model that makes many pastors feel de-skilled. You know, that they're muddling around at the edge, and then there's these experts out there. And I think it's really helpful for us to see how the medical model thinks and operates in relation to depression, so that we can get what its strengths are as well as what its weaknesses are, and so that we can learn to work cooperatively and collaboratively with professionals, because some of the people we see may need to see a professional, many won't. And one of the great, I think, gifts of, say, the biblical counselling movement, it's reminded us that we mustn't professionalise relational pastoral care of one another. We don't need to put a white coat on our pastor to learn how to be alongside each other in shepherding. And there's so much that in the past we've, you know, farmed out to the professionals that can be done in our church life together. And I think that's been one of the great ministries of biblical counselling. It's helped us recover that perspective. My own view is that still leaves a place for professionals who look at things in a particular way, have a particular expertise. We should be wanting to learn from them as much as we can. So that's the aim of this morning, right until lunchtime, is I want to share with you how the medical model works in relation to depression. Okay. So what is the medical model? It understands that there are disorders of what we might call oh, by the way, all these slides, you'll be able to download them. If you just Google Glyn Harrison, the first site that comes up, click on that, go to resources, and you can download it in a PDF file from tonight. So that would just save you having to write everything down. See people get cameras out, you know. So it's all there. So that might enable you just to engage a bit more. But the medical model is based around the idea that our mental life is a hugely complex process, which is capable of becoming disordered, as with any other system of our biological, physical, mental makeup. So, you know, our mental life has an important task to enable us to function appropriately in the world. And in order to do that, it has to sift through vast amounts of information that's coming in that we're processing, and process it appropriately to the task in hand. So, for example, he just sort of went like that with his nose over there, and I noticed that. Why did he do that? What's the salience, the significance of his doing that just then? It's quite worrying. Depending on how well my regulatory systems are working. Because if my regulatory systems are saying, look, you're here to engage with these people and have a lecture, it's of no relevance that he goes like that. But if my regulatory systems are malfunctioning, beginning to break down, I may wonder whether he's trying to send me a message right now. And that what may be going on is that my ways of understanding the world are malfunctioning, getting distorted. In a similar way, something bad happens to you. We all know how our mental life reacts to that. So when you have a huge disappointment, you feel crushed in your spirit, hard to concentrate, the optimism drains out of you, and you have to grit your teeth and get through the next few days of low mood and disappointment. And you're a little off your food, you don't want to go to the cinema that you'd planned, that you react in a way that your mental processes will self-correct because you have to get on with life. You can't stick in this position all the time. So our mental mechanisms do self-correct. They regulate our reactions to our environment. But some people, after 2 or 3 weeks, they're still stuck in this downward mood. And doctors say, I wonder whether something's going wrong with those regulatory mechanisms. And that's the way that the medical model thinks. And that way of thinking has strengths and it has weaknesses. And we'll need to come back to that. I do think I need to emphasize this is just a model. It's just a way of looking at the world. It's just a lens through which you look at the world. And it's imperfect and it has some real flaws in it, particularly if we push it too far as an explanation of everything. Because human beings, they always defy being taped down to any simple explanatory model. It's always a way of understanding which has its strengths and its weaknesses, any model. So the medical model has this idea of a breakdown or disordering at some level of the regulatory systems of mental life. For example, an excessive or disproportionate response, an abnormal response that just isn't shared by most people, abnormal in that sense, or present to a degree that you can't function. You can't get to work, you can't look after your kids, you can't concentrate, you cannot, go around your daily business. And when any of those facts are present, doctors start getting interested and say, I wonder whether there's something going on here. So that's the first point, this notion of disordering. The next point is the medical model, particularly in psychological issues, is syndromal. By that I mean, it doesn't have any scanning or blood tests. Mental disorders are too complex to be, usually. There are 1 or 2 that can be understood in terms of a blood test, but mostly they're too complex and too mysterious to be understood in that way. So as much as doctors love scanners and x-rays and blood tests and blood pressure and all of those things, it makes us feel important and validates our professional status. So in the psychological disorders that there aren't those nice simple tests, and we really are still at the level of looking for patterns of change and spotting patterns of change which we recognise tend to follow certain courses, and it's very much at that level. And people say, oh, that's the trouble with psychiatry. It's always just describing what's going on. It doesn't have a strong biological underpinning. But actually, a lot of medicine is still syndromal. Most pain disorders, migraine, it's very hard. There's no blood tests. There are no hard and fast brain scans for migraine. You depend on what the patient tells you. You depend on a particular pattern going on that you can then make predictions from, or certain treatments work with it. So it's very syndrome-based, the medical model. But it is grounded in a basically secular concept of causation, which is called biopsychosocial adversity. And the medical model grew out of secular understandings of the human being, from neuroscience in the 19th century through Freud, Jung, Adler, the behaviorists. All of these were operating within looking at the human through a secular lens. And that is how the medical model mostly operates. And so what we have is this biopsychosocial model, these three areas of adversity overlapping to produce ill health, or if they overlap well, to produce health. And then we come along as Christians and say, then we've got the spiritual over here. And so our big problem is always, how do we relate the spiritual to the medical or the secular? And we get into arguments with one another. And I don't want to recap what Richard does so much better in that article, because Richard really elegantly looks at the different ways in which you can relate these two worlds. Because at one end, one extreme, you've got people who say, it's psychology only. Spirituality is for sad people. It's for people who are wasting their life. The future is in the biopsychosocial understanding of the human being. This is a secular philosophical stance. They're perfectly entitled to it, but that's what it is. And at that extreme, there are people who would be amazed that we're sitting here wondering what the spiritual perspective is when they see the future in this highly secular philosophical terms. At the other end of the spectrum, there are people who say, "Oh, this is rubbish. We've got nothing to learn from psychiatrists. They've simply professionalized human adversity, and in their white coats, they've created power structures in which gives them power over people and an income and prestige. And it's all a sort of a medical takeover of what basically are problems in living and really need to be understood through a biblical lens. And it's Bible only. And the only model that they would entertain is one which is understood in terms of some spiritual model. And so you've got those two extremes. Now, we will, between us, settle on different ways of bringing those things together, if at all. There'll be one or two here who'll say, well, actually, I'd like to defend being out here, at the Bible-only model. And we'll all settle in slightly different ways of bringing the two together. But my approach is essentially integrationist. And by that, I mean, I don't see these two as separate things. I see the biopsychosocial model as being integrated within the biblical worldview, because all truth is God's truth. And so, for example, if someone comes to you and they're hyperventilating and they're having a panic attack and the heart's going faster against the chest pain, but they've been to the hospital before and the doctor says there's nothing wrong with their heart, and they're ventilating and they're panicking, I could tell you the really good thing to do is get them to blow into a paper bag, because what's happening is they're over oxygenating their blood by hyperventilating. That's causing shifts in calcium around their nerves, which is making some of their nerves go twitchy, which is making them think they're dying, which is making them breathe even faster. So you need to get a paper bag, get some carbon dioxide in, which restores the calcium levels, and they just begin then to go down. Now, where's that in the Bible? Not anywhere. Tell me if there's a text. But I'm not going to surrender that insight to any secular models, because all truth is God's truth, and we're called to wonder at the world as God's creation and to rule over it and to have dominion over it. And so I always saw my secular work as a part of my dominion of God's world that he calls us to. And if someone's found this out about calcium and hyperventilation, That's great information that I want to integrate with my patient's problems. But then once she's settled down, or he's settled down, we may have a lot of talking to do about the secret affair he's been having and the guilt he feels and the issues he's now got to look at. Or we might want to talk about how he's retired and got depressed, but wouldn't you get depressed if you'd idolized your work as he has all his life? You see, now those are a spirit, that idol model, for example, is quite an interesting spiritual perspective on that man's problems. Are they in competition, those two, the paper bag and the mod? Of course they're not. But I can tell you, if he's hyperventilating, it's no use talking about idols. He won't hear you. He thinks he's having a heart attack. He doesn't understand why his hand's going like this. And so what I think the great gift of Scripture is, this holistic view of dominion, you know, the great creation mandate that we have to rule God's world, is that we plunder whatever science can give us. And yet we don't let science rule us. We're the ones with dominion. We're the ones with the lens which is Bible-shaped. And we look at the world through the lens the Scripture gives us. And we seek to integrate these things. The only problem is, it doesn't make a great book, this integration model, because it's so complex. You know, if you want to sell a book, you've got a simple idea with a great title and flog it as hard as you can as an explanation of so many things as possible. You know, people like simplicity. They like someone to say, I'll tell you what's wrong with you. You know, and we like a simple model. And this integrationist approach, it's a little bit of this, it's a little bit of that. Sometimes it's more of this, not so much of that. But sometimes it's a lot of this, not much of that. To make a great book, it makes a long course. It makes a more difficult approach. And both Richard and I, we'd love to just give you, some real answers. We'd love to send you away with solutions and neat packaged, sort of programs, so that you've got an algorithm. So a person comes with A, go to B. Ask question. If it's yes, go to C. If it's not, go to D. It's great. We'd all love that. And I just say, don't believe people who bring those simple solutions, because we're made in the image of God. And you'll never be taped, never be simplified in that way. We need to bring all the gifts of God to help one another. And so this is the integrationist approach that I've always practiced within. But because I've practiced in a secular environment, I've had, nevertheless, although I felt my mandate to use biological approaches or certain psychological models is still there in Scripture, I'm afraid my employer doesn't give me the mandate to talk to someone about the idols of their heart, or to talk to them about their spiritual drift, or their, it doesn't give me that same permission. So I have to sometimes be pragmatic and surrender that part for a while, or explore with that person another way of getting that kind of input. Richard has his own skills as a psychiatrist from his own background in psychiatry, but can work in a much more explicit biblical framework while still using those skills. So in many ways, he's been able to function in a more integrated way than I have in the secular world. But that's the nature of the beast, we have to work within these constraints. So what I'm going to be talking about is how I'm going to continue a bit further down this route of how doctors operate in relation to depression. And depression, of course, is a disorder of emotion. And emotions are brief, complex reactions of an organism to significant events, with subjective behavioural and biological strands. So, something really sad happens. You sense a slowing in yourself, a distractibility. It's hard to concentrate. Your mind keeps going back to this thing. It's a holistic response. And subjectively, we have feelings which fluctuate, or psychologists then differentiate that from moods, which are more longer lasting and intense. I don't think we need to worry too much about these conceptual issues. But the psychologists talk about there being a range of basic emotions, and this is one model. And you can see that you have these are arranged oppositely, because often we think emotions just sadness and happiness, but if you think about it, there's quite a range of emotions. Disgust is a powerful emotion, and it's an aversive emotion, and it's in opposition to acceptance, which is a move towards something, an inclusive emotion. There's this emotion of anticipation. It's a quite distinct feeling as you anticipate something. And it's very different from surprise when something just comes out of the blue. Anger, fear, but the ones we are majoring on today are sadness and joy. And so let's go down the sadness range. If you remember, we said sort of emotions are complex reactions, so they involve subjective, behavioural, and biological strands. So that's mood, cognition, and biology. They're the three areas that we think about. And so, as we get sad, we're all aware of that subjective sense of our mood being lower. But we're also aware that pulls in other aspects of our mental life, our cognitive function. So we find ourselves defaulting to a more negative, pessimistic appraisal of our situation. We find ourselves defaulting to a self-blaming appraisal, defaulting to negative appraisals of our personal worth. And we'll all have experienced this during periods of, you get a bad result, something goes wrong in your life, and for a while you think that, here we go again. And I wonder what's going to go wrong next. Typical, and the world, we begin to filter in the more negative, reflecting our basic mood state at that time. Now, this is just a normal part of the fluctuation of life. And it can pull in biological features, that we sense a slowing down, a withdrawal of interest, feel like eating. All of these are part of a normal holistic response to usually loss events, disappointment. And doctors are particularly interested in this because this is part of the normal up and down life that we all experience. Doctors become interested when there's a more severe alteration in each of those areas: behavior, emotion, thinking, and biology. So behavior, thinking, emotion, biology. And what happens in depressive illness is that all of those different aspects of our function are pulled down. Now, you'll all be aware of something called mania. You heard of mania? Mania is in bipolar disorder. Mania is the opposite of depression. It's a very interesting phenomenon because in mania, the arrow simply goes up the way. And as in depression, everything, the totality of the organism, the person goes down. In mania, the totality goes up. So let me unpack that a bit more. In depression, your mood goes down. Your thinking slows. Its content biases to selecting the negative, pessimistic, low self-worth, guilt themes. Your behavior slows. You lose interest in your environment. You don't want to go to the cinema. You don't want to talk at great length. You're not interested in something new. A new book that you don't want to read. There's a withdrawal from the world. And biologically, there are some changes that can be measured, some changes in brain rhythms, for example, a slight shift during some of the night rhythms that happen. And doctors start getting interest where all four go down together to quite a significant degree, and I'll come back to that in a minute. But in mania, what's interesting is that all of this goes up. So your mood is elevated, you feel terrific, you feel good, pleasurable, engaged. Your thinking speeds up, full of ideas, great, lots of things tumbling through your mind. The content of your thinking, instead of being negatively biased, is positively biased. So you are looking for the next great thing to happen. Life's full of possibilities. There's another one. I think we can make something of that. Oh, thank you. Let's go. And there's a huge shift of cognitive bias toward selecting in the positive. And whereas when you're depressed, you have a down on yourself, feel guilty and worthless, and lack confidence about yourself. In mania, you have an expansive sense of self, so that you are optimistic about the future, you're very confident about your skills, and you are, you have a very inflated view of your self-worth and importance. And similarly, biologically, there's a speeding up of the personal agitation, general movement, increase in appetite, and so on. So this is quite interesting. So you'll see why doctors are interested in what's going on here. These people who move up and then sometimes they move down. And so in depression, what we're looking at, as we've said, we all experience times where we have this to a mild degree. Doctors say that someone has a depressive illness when these kind of factors are present, where the response is disproportionate, sustained, you lose reactivity, there seems to be an autonomy about the mood. It may adopt what's called the diurnal rhythm, which is worse in the morning and gets better as the day goes on. And there's a pervasiveness about this. Okay, so you might say, well, that's not very clear cut, is it? The answer is no. You've got to make a judgment as to, am I looking at something that's part of the fluctuation that we all experience, that given what this person's gone through is understandable? Or is there something going on here? Is this person becoming ill with their sadness? That's what the doctor's asking, you see. Is this person becoming ill with their sadness? In the sense that this is now disproportionate. Yeah, that was a bad thing happened, but that was a month ago. And we're still grinding on, and this person doesn't react. Someone comes in with a bunch of flowers, they don't respond. There's no reactivity there to the mood. It seems to be locked into a process that's almost autonomous. The mood is grinding on with a mind of its own, you see? And that, when doctors see that, they think, I think this is someone who's getting ill with their sadness. This is more than just the normal reactivity to life. And this diurnal rhythm is fairly typical, that someone wakes earlier than usual and feels really low first thing, and then gradually gets better as the day goes on. So doctors routinely will ask, any particular time of day when you tend to feel lowest? Someone says early in the morning. That again, none of these is a deal clincher. Just because you've got depression, you've got to make a judgment in the round as to whether this is really something that's becoming more of an illness or something that maybe a doctor could help